Hi, everyone. My name is Mark Mikkelsen, and I'm joining you from Philadelphia, Pennsylvania, in the United States. This topic is going to be how do we maintain the well being of ICU doctors? So, I received grant funding locally to improve the well being of critical care clinicians at Penn Medicine to study this. Otherwise, I have no financial conflicts of interest. So, first, how do we improve the well being of ICU doctors? Well, we need to define it and we need to measure it. We also need to acknowledge that while we focus significantly on burnout or the negative aspects of our role and our work, we also need to take stock of the positive aspects of our role and work. Burnout syndrome has required and demanded a great amount of our attention. We define it as work related conditions that lead to one of three symptoms, including emotional exhaustion, depersonalization, also known as cynicism, and reduced sense of personal accomplishment. And while focusing on the negative is vitally important, and we do aim to mitigate burnout, we also need to acknowledge and optimize professional fulfillment through something known as the Stanford Professional Fulfillment Index, which we've studied and used to study critical care clinicians locally. One has the ability to assess the degree of positive reward that we as individuals derive from our work. What does that mean? Happiness, meaningfulness, contribution, self worth, satisfaction, and the feeling in control when dealing with difficult problems at work. So now that we have an understanding of what we mean by well being and we recognize the importance of measuring it, we can dig in a little bit deeper. First, we need to take stock and recognize burnout symptoms in ourselves as well as in our team members. They involve both psychological symptoms as well as physical symptoms. And over the last several months of the COVID-19 pandemic, you likely have experienced both psychological and physical symptoms yourself, as well as seen it in your colleagues. That is a vitally important step towards maintaining and improving well-being, is recognizing it in ourselves, acknowledging it, taking stock when we need a break. What are the repercussions of burnout? This is not just specific to physicians, but to all of us. It can take a toll on our own well being, and studies have shown that it's associated with depression and with suicide. It has an impact on our health system in terms of staff turnover with huge financial implications, and it takes a toll on the impact of our patients with a reduced quality of care provided when we as a team or we as ICU doctors are burned out. So, how common is burnout and do we need to take this seriously? In short, yes, we do, but it is not new. In fact, if we go back to a landmark study published in the Blue Journal in 2007, Embriaco and colleagues, when they studied ICU intensivists in 189 French ICUs, they found that nearly one out of every two ICU physicians surveyed were experiencing a high level of burnout. Fast forward to 2019, and that number, looking at United States physicians through the Medscape survey, nearly one out of two again, physicians were burned out. And that was the exact same number when they looked at specifically the critical care physicians. So burnout is common. It is something that we need to take seriously, but it is not new, and it has been with us for nearly 2 decades. So I highlighted the importance of measuring burnout, i.e., don't just stand there, do something. Well, the National Academy of Medicine put forth that what we need to do to improve physician, but I would argue just all of us, clinician well being, we need to measure it. We need to then develop and implement interventions, and then we need to remeasure it. Here, I'm highlighting two survey instruments that are recommended by the NAM in this Action Collaborative Clinician Wellbeing and Resilience that we have used to study well-being, both the positive and the negative, over the last 3 years. I highlighted earlier that it takes a village, and to hammer home that point, the reality is that we cannot improve ICU physician well-being without taking stock of the impact in terms of burnout on the entire team. When we looked locally, We found that burnout is common across all critical care roles, including advanced practice providers, nurses, critical care pharmacists, and physicians. And we also need to recognize that as a fundamental goal, when we aim to improve or optimize professional fulfillment, physicians experience a tremendous amount of fulfillment through the work that we do. Our other team members may not as much, and that's an important area of investigation over the next several years. I'm going to talk about risk factors shortly, but I'm going to highlight here that clinicians, this is a confirmatory finding, clinicians who are earlier in their practice are more likely to experience burnout. This was found previously amongst ICU nurses. Here, we found it across all providers. We also need to take stock that there's an ebb and flow to the burnout. We've focused primarily as a community on the burnout that teammates, ICU doctors experience when on service, but the reality is we don't spend every day on service. And when we examined this, what we found is in fact that an ebb and flow to burnout exists. When on service, when surveyed at the end of a clinical rotation, burnout was hitting at that 40 to 50% mark. But we take a deep breath and we have the ability to recharge with decreased burnout when off service, when either seeing patients in clinic, uh, doing clinical research or other research endeavors, administrative work, or other overall work. And importantly, professional fulfillment when on service, when off service, remained quite high. And I want to highlight professional fulfillment numbers here are nearly twice that which were identified in the initial validation study. In other words, ICU physicians are incredibly fulfilled relative to the norms from the original studies that looked at this specific element of well being. So, what are the drivers of burnout? I had highlighted that there are different frameworks to think about this. It does involve the person, meaning who we are as individuals, how resilient we are, but also, as I already alluded to, the fact of how early we are in our career. Also, we need to focus our attention on those in the first several years on the job. The ICU environment and organizational factors also play an incredibly important role. Workload, time and again in studies, has been highlighted as a clear driver of burnout. Interpersonal conflicts, moral distress are other drivers of burnout. Organizational factors, ones that we'll get to shortly, including when we work more night shifts, when we work more consecutive days, are associated with an increased rate of burnout. So, when we talk about organizational strategies, I wanted to bring your attention to a general concept, which is what drives us. What is it that motivates us? And I draw our attention to the work by Daniel Pink in his book entitled Drive, where he highlighted that extrinsic motivators are less powerful than the intrinsic motivators that drive us to be our best. And he brought forth three specific principles: autonomy, mastery, and purpose. When we think about how can we improve the well-being of ICU doctors, we should lean on these three principles. There is great purpose in the work that we do. We can encourage flexibility, give people the autonomy that they deserve and that they demand, and then provide the skills to be masters of the domain of critical care medicine. We can also derive value and lessons learned from well being work outside of critical care at the organizational level. So, to get back to that original concept of measure it, listen, implement interventions to improve well being, and then remeasure it, we began a project about 3 years ago locally. This was subsequently published in the Blue Journal last year. And when we began, what we found was one specific rotation had an incredibly high rate of burnout. At the end of a 2 week rotation, what we were finding was nearly all of us were feeling burned out as measured by one of those two instruments. Fulfillment was there, but it was lower than what we were experiencing on other rotations. So, as a community, when we listened to one another, we realized that there were some things that were immutable. for example, the rate of mortality on this service was a driver of burnout. And yet, one thing that we could control was the length of the rotation. And so we worked together, connected with our School of Medicine colleagues who had encouraged, for continuity reasons, in working with house staff to stay to 2 weeks. There was a clear acknowledgement across all service lines that we needed to do something once we saw these rates of burnout. And what we did was we switched up our rotations from 2 weeks to 1 weeks for those that were able to do that. And we found a clear reduction in burnout by measuring, listening, learning, implementing, and remeasuring. I provide a couple of quotes that sort of hammer home the point of what did it look and feel like at the end of these two differing rotation lengths as just one strategy, but more importantly, the concept applied here of measuring, listening, learning, and then remeasuring as successful strategies to improve well-being. I also wanted to highlight that in the last several months, we did see a spike in our rate of burnout. And I think that's important for us to collectively acknowledge. Burnout has increased over the last several months. I hope, and we will take stock over the next several months of our ability to get back to that nadir that we had appreciated. But if you, amongst your teammates, were sensing an increased rate of burnout, the reality was it probably was there. We need to acknowledge it, tend to it, recharge, get back to it. Other strategies when we think about how can we improve well-being. One, take pride in the work that we do. Recent evidence highlights that the work that we do at the family level is acknowledged as high quality end of life care. And we have the ability to ensure that we understand our patients to provide goal concordant care, lean into what draws us to critical care, the compassion that can actually optimize our own well being. I wanted to, if you are not aware of the serious illness conversation, give it a try. It's an opportunity to standardize just that, understanding our patients, their goals and preferences through an evidence based approach. We rolled it out locally, found tremendous value in that. Beyond this idea of autonomy, mastery, and purpose, there's also the importance that just as we focus on professional fulfillment, there's great value in looking at the positive as well as the negative. And then last, one strategy is to look outside of the ICU, to incorporate post ICU activities into your professional portfolio, not just as an individual, but as an organization. When done, we found that longitudinal feedback from understanding our patients in their longitudinal health history, the opportunity to be more fulfilled does exist. It can improve as well ICU morale. And so, last, how do we maintain the well being of ICU doctors? The general refrain here is measure it, listen, learn, implement interventions. And through that approach, I think we have the opportunity to meet the mark and improve well-being of ICU docs as well as the team. Thanks so much. Hope you enjoy the rest of this session.